musty apple.
Okay, we are live, Aarti madam.
Right. So I'm just sharing my screen. You have to give me
Yeah.
permission to share.
Yes. 1 minute, ma'am. Yeah, you can share your screen now, ma'am.
Right. You can see my screen, right?
Yes.
Right. So good evening, everyone. Welcome back to the Blast series. And we've done the initial assessment in part 1 of our ovarian endometriosis series. We've spoken about surgical management in part 2. And today we are going to talk about the conclusion, that is the post-surgical follow-up period. Now, for those of y'all who have not seen the previous ovarian endometriosis series, it was really insightful, and we spoke pearls and pitfalls in surgery for ovarian endometriosis last time. And before we hand over the session to Jay and learn from him about the follow-up period and about the most dreaded complications in this surgery, I want to just mention a very profound statement which I loved, that the eyes do not see what the mind does not know. That is, it's very important that we are aware and we recognize a complication in the post-operative period. And Jay, uh, let's go through what are the early and late complications associated with this surgery. We'll first talk about the dreaded part, and then we go ahead with speaking about the simple follow-up tips which you'd want to give us. So over to you, Jay. What type of surgery or intervention is associated with what type of complication? And I've mentioned all the questions there. So stage is...
Yeah. So, see, one thing you must understand. Usually, when we do an ovarian endometriosis, at that point in time, we will also do some amount of peritonectomy because that little peritoneum is affected. And simultaneously, you can also have distortion of the fallopian tubes, especially the fimbrial end of the fallopian tubes. Okay. So if you are not careful enough, okay, then you can have some tubal factor which gets associated causing damage to the tubes. Okay. And if you are not careful in doing peritonectomy, you might just nick the ureter because the adventitia of the ureter is attached to the peritoneum. All right. One more thing people should remember, this ovary actually goes and gets adherent to the lateral pelvic fossa, okay, of the peritoneum. So when people try to take it out, no, the chocolate thing comes out, but some microscopic disease remains on that lateral peritoneum, which bleeds, okay. And if in case you just let it be as it is, and if you just coagulate it, you will not be able to do a deep coagulation because 90% of the situations you will understand that the peritoneum there is thickened. Okay. So please remember that particular peritoneum has to come out. Okay. 100% it has to come out. Okay. That is one thing. Obviously, the role of having a complication in deep endometriosis is different because when you are having deep endometriosis, you are operating onto the bowel predominantly. And when you are predominantly operating onto the bowel, especially when you are just doing rectal shaving, the chances of perforating the bowel is much higher. Okay. This chance is greatly reduced when you do discoid excision because in discoid excision, I think we've done 3, 4 already at Hyderabad with Aarti madam. And in discoid excision, you are firing 3 rounds of staplers. Okay. So when you fire these 3 rounds of staplers, the chances of having an otherwise perforated injury to the bowel goes down very, very drastically. All right. And obviously, if in case you are doing a segmental bowel resection, it may be associated with a leak. All right. And when it is associated with a leak, it can be an early leak or a late leak. But then, that is something which we have to keep in mind, practically speaking. All right. And that is something which we have to keep it in our head when we are operating deep endometriosis. All right. See, for practical purposes, we don't leave a drain. Okay. Inside any of these abdomens. So if you see, we've almost never left a drain in so many cases which we have done. Okay, the reason for not leaving a drain inside is because, frankly, there is no oozing. So you have achieved a good hemostasis at the time of closure. And when there is a good hemostasis at the time of closure, the peritoneum will just epithelialize laterally from the healthy peritoneum and it will heal off beautifully. Okay, so you really need not worry about that. Just keep one thing in mind. Okay, as far as a deadly complication which Aarti madam is talking about is concerned. This deadly complication is best picked up by measuring the pulse of the patient. Okay. A tachycardia which doesn't settle after 12 to 14 hours of surgery. See, first 10, 12, 8 hours, 10 hours, it could be related to the pain. Okay. But if the tachycardia doesn't settle within 12 to 14, 16 hours of surgery, you need to be cautious. Okay. Just keep that in mind. That is the earliest sign, a non settling tachycardia. Okay. After that, of course, you can have abdominal distension, paralytic ileus, fecal peritonitis, fever, sepsis, 100 other things. But persistent tachycardia is a take home point, in my opinion. Okay. Because see, when it is so early, no, even CRP is going to be falsely elevated in very early surgery. So you can't really rely on CRP for an early complication. You can rely on CRP for a late complication. Okay. So I think just keep that one little point in mind. Uh, Uncommon complications seen. Yeah, I mean, see, probably with the number of cases which we are operating for endometriosis, seeing complications is not a rare thing, right? So we have seen complications as far as leaks are concerned, and the latest leak I've had, I mean the one which presented the last, okay, was approximately 14 days after surgery in a dermatologist. Okay, this is around 1 year back. But fortunately, we had monitored her with CRP. Okay. So because we monitored her with CRP, again we were saved. CRP was elevated to 90, okay, in that lady. And we picked it up very, very fast. And we told her that you need to put a laparoscope inside. We put a laparoscope. There was an anastomotic site leak, and she ended up with a temporary ileostomy. Okay. Apart from that, I have seen three, four bad cases where I've had to remove the complete diaphragm, especially on one side. And when the endometriosis on the diaphragm is so much, it is associated with a lot of post-operative pain. Okay, that is something which people have to keep in mind. I have done and shown many umbilical reconstructions, which we have done for umbilical endometriosis. Okay, I have shown very bad inguinal endometriosis where it is going inside the femoral artery and vein, and it is going to require saphenous patch over that. You need to put a bulldog. But then these are very uncommon cases. They happen 1 to 2 times in a year. So just keep that in mind, but nothing else apart from that. We mentioned about diagnosing bowel and ureteric injury already. One thing about ureteric injury, especially urine leak, basically urinary ascites, is that the serum creatinine and ascitic fluid creatinine, okay, is very different. The ascites, which causes urinary ascites, basically will have a heavy concentration of creatinine. So usually the value of creatinine will be elevated to more than 15. Okay, when you have a urinary ascites on an ascitic tap, keep that point in mind. Okay, and remember, urinary ascites is very, very toxic. So I mean, the patient will be very, very toxic in a urinary ascites. Keep that in mind. Okay. Uh, Keeping your nerves calm and thinking logically. Uh, See, that one comes out of experience. Second, it's just how your temperament is. So there are certain people who are temperamentally chilled out and they will not really get panic. There are certain people who panic on everything, you know. So one of the things probably which you can keep in mind in order to keep yourself calm is to try and get married. Okay, that usually settles down majority of the males, and they learn how to be calm in most of the situations. And I think the same will help you in endometriosis as well. Okay, so probably that. Okay, but we can move on to the next slide.
Now, just a few questions here about complications, Jay.
Yeah,
You said persistent tachycardia is something that we have to
very
always
common. Yeah, yeah.
keep in mind. Now, when do you start using CRP as a way to monitor uh,
See, when we do
possible
bowel
bowel?
endometriosis, see, when we do bowel endometriosis and if a discoid excision has been done or a segmental bowel resection has been done, the standard protocol is to do CRP 5 times. Okay. So there is a day 3 CRP, post surgery, day 6, day 9, day 12, day 15.
Hmm.
Okay. Usually on day 3, the value will be close to 90, 100 because it is an early inflammation, no, which is settling down. It is not a very great marker.
Hmm.
Okay. At day 3.
Hmm.
At day 6, usually the value will be less than 50. At day 9, it will be less than 20. And day 12 and day 15, it is going to be less than 10. So at any given point in time after day 6, if this value is more than 80, it is a marker of a leak somewhere. Okay, some inflammatory leak somewhere. You really need to monitor that patient, do a CT scan, and almost always you will end up putting a scope. Trust me.
Okay. So do you recommend, that in patients where we've done some sort of a bowel, rectal adhesiolysis or some sort of an intervention on the bowel,
No,
we do the CRP on these 5 days?
no. It is only to be done if you have used some form of resection in the form of a disc excision or in the form of a segmental bowel resection. No other case.
And I've also noticed that you always check for the integrity of the bowel with methylene blue
Always.
interstop so that you don't have to deal with all these
Yeah,
complications.
always. I always do that. It is a part of my habit. It's even if I do a simple TLH before the abdomen is closed, I mean before the ports are closed, my nurse will put methylene blue in the bladder also. You must
Right.
have seen that.
Yes,
No,
I've seen.
they will test it with 100 cc methylene blue. It will be written down in the notes that immediate testing was done, everything was fine, patient came out. It takes 1 minute more, honestly, and we routinely do it.
Right. One more question here, Jay. How early and how late can these patients present with post-op pain? How early and
Pain,
how, because we've seen, patients even present 20 days later with pain and who may be having a suspicious leak.
yeah. See, usually early pain, as I said, first 1 day pain is usually surgical. But if
Right.
the pain is persistent with tachycardia, that means there is a peritonitis somewhere.
Hmm.
The usually this leak after 15 days is rare to see, very rare. It is a micro leak which basically gets converted into an abscess and then it opens up. Basically, all right, that's how the mechanism is. But it is very rare. So the latest I have seen is at 15th day in my career. Okay,
Hmm.
usually it will be on the 8th, 9th, 10th day.
Okay. So, what about urinary ascites? How early and how late can they present, Jay?
See, the typical thing with urinary ascites is if there is a thermal injury, it will present very late. After 10-15 days of surgery, there will be abdominal distension, usually. But remember, the good thing about urinary ascites is patient is passing urine.
Hmm.
Okay. Patient is passing urine, there is abdominal distension and there is tachycardia.
Hmm.
Okay. Common thing. Very common. Okay. Uh, and it's very confusing because people think, Are, she is passing urine. So how can she have this? But in that situation, if you do a CT scan, you will find out that there is a contrast leak somewhere, you know, coming inside the peritoneum. That is diagnostic of it. Of course, you can do an ascitic tap and find out if it is actually urine, but it requires reimplantation and it has to be operated immediately.
Right. Um, Moving on, Jay. Now, what about immediate post-operative care? Very simple questions here for you.
Yeah. See, we normally always give a tab block, as you have noticed. In almost all post-surgical patients, post-surgery, we give a tab block. This is something which greatly reduces the pain requirement of that patient. All right. Antibiotic of choice should be based on what your microbiology department in your hospital has suggested. But usually the standard is to give ceftriaxone or cefuroxime, one of the two. Okay. Uh, when I give post-operative medical therapy, see the indication for post-operative medical therapy is like giving chemotherapy. Okay. You should give it when there is no visible disease of endometriosis. Okay. And the patient is planning for conception. Let's say she comes and tells you, I'm 27, I've got married, you have operated, thank you so much, but now I'm planning for a child when I become 29. What do I do for these 2 years? These 2 years, you can probably keep her on continuous OCPs, put a Mirena inside the uterus, give Dynogest, something like that. Okay. Apart from this, there is no indication of giving medical management on an incomplete surgery. Okay. Are bowel is adherent. So I drained the ovarian cyst and I came out. That is not a complete surgery. Okay, that is an incomplete surgery. This has got no role of medical management. Okay, so there should be no visible disease, and then fertility should be a distance away. Common in teenage girls, young girls whom we operate 17, 18, 19, 16. In these type of girls, it is common. And in these girls, we may give prolonged courses of oral contraceptive pills till they get married to have a good suppression. Okay. Then the next question is, how soon to start fertility treatment? 1 month. I mean, if the tubal this thing is okay, next cycle they can start. Yeah.
Hmm.
Which cases are prone for recurrence? Multiloculated bilateral endometriomas, highest recurrence. Okay. Unilateral endometriomas, least recurrence. Okay. Bilateral endometrioma has a 95% chance of deep endometriosis. So if you have done only endometriosis clearance from the ovary and left the rectum as it is, 100% recurrence is going to happen from tomorrow morning. Okay. So just remember this thing in mind. Just take it as a take home point. Okay. First you do complete surgery, then you worry about recurrence. There are many people who worry about recurrence after doing just cyst drainage. It will recur tomorrow morning only. Okay, and if you are lucky within 6 to 8 hours, because that ovary is continuously going to secrete chocolate fluid. So till you don't do surgical excision, which according to guidelines is currently the modality of choice, unless we have a medical management which cures endometriosis. Okay, which is probably 45 years away. Okay, so just keep that in mind. First, do a complete surgery, then give importance to recurrence, because your complete surgery will really reduce the recurrence. Trust me. It will reduce the AMH also, because the large amount of ovarian cortex is going to get compromised. So it will reduce the AMH. But the AMH eventually reaches a logarithmic value of 90% of the original value within 6 to 8 months of surgery. It's not that today you operate, next month AMH is okay. That will only happen if you have drained it and come out. Okay. If you have done a cystectomy, first the value will go down. After this value goes down, slowly, within 6 to 8 months, it comes back to 90% of the original value. It will never exceed the original value. If it exceeds the original value, then either you have not done cystectomy or the previous value was wrong. One of the two. Okay. So just keep that in mind as a point. Okay. I think this is the most important point or question which you have asked in this entire blast series so far. Okay. Which is importance of consent, counseling, and documentation. See, this has to be a procedure specific consent. You can't take a standard laparoscopy consent and do endometriosis. Take a procedure specific consent. I think Aarti madam has seen my consents for endometriosis. They run into 8 pages, correct?
Right.
And the 8 page consent will include everything. The patient signs on it, you happily operate. The patient will ask you doubts, you happily answer. But if the patient tells you remove this clause, add this clause, okay, then you don't operate that patient. Very simple. It's very simple. Like for example, somebody had messaged that they are clicking photos of the ovarian cyst wall after removing it. Have they taken consent of the patient before posting it on a WhatsApp group? Of course we have taken. What do you think? We have not taken? We take consent even for touching them. Okay. So we know how to be safe. But it is important that all of us know how to be safe. Okay. And I think that will take you a long way. So many a times people are worried that if I take an extensive consent, patient will run away. They will run away, but they will come running back to you only. Okay. At double speed. So don't worry about that. No patient is going to run away if your consent is extensive. Okay. Only two category of patients will ask you questions. One who think they are doctors. Okay. So they will ask you questions. Second, who don't know anything. So they will also ask you a question. कि भाई ये सब जो लिखा है वो बराबर है ना? You just have to answer yes. Okay. And then 99% of them will sign. So don't worry about extensive consents, please. Okay. Time duration for follow-up. If a patient is wanting to have a pregnancy, then definitely till she is planning for a pregnancy or once she is pregnant. Okay. And I can't read that. Your experience having done such complicated surgery. Yeah.
Complicated
So
surgery.
bowel endometriosis and bladder endometriosis and ureteric endometriosis are part of deep endometriosis. Normally, we try to follow this, till at least 4 years. That's what I do because I like to follow it up. Most of them just come and say a hi on Zoom. Okay. And it
You
is
call
good,
them how
to be
often?
honest. Once in a year, madam.
Hmm.
Just once in a year. And it is good. Genuinely, it is good. So it is something which I like to do, and it is something which they like. That Carrie, the doctor is really concerned. So they just meet us on Zoom, and most of them are going to be fine. Some of them are going to come up with a vague complaint just because you are speaking to them. So all these type of things are common. But then I think it is an important part because it helps you generate a lot of data and when you have a lot of data, published or unpublished, it helps you speak with confidence to the next set of patients. Okay.
Right.
So you can proudly tell your patients that, I've operated somebody 4 years back and she's fine. Do you want to speak? And because you've maintained a follow up, that other guy is also willing to speak to this new guy. So all these small things really help the patients in a long way.
Right. Calling them back and also doing maybe a scan and, just being
Worth
sure.
it,
Yeah,
but
that
it's
also is
worth it, madam. Yeah, it's worth it. But then unfortunately, I happen to deal with patients who are coming from a lot of different parts of the country. So
right.
I don't call them for a scan. I just ask them if required to do a scan in their hometown.
Mhm. Okay. So every 1 year for at least 4 years is what you were saying is your follow-up period.
Yeah, yeah, yeah. For
Right.
deep endometriosis, huh, madam?
Of course, of course. And what about some experiences of yours, Jay? I mean, because you're doing endometriosis of the mandible, endometriosis of the, of every possible structure in the body. So something about your experience with dealing with complications. I know, touchwood, your complication rate is, over the years, it's less than 1%. But how have you reached there? Do's and don'ts.
See, contrary to the popular opinion, okay, uh, it's actually me who is doing these surgeries. Okay, I don't really call up people from outside to operate. So that is the biggest killer. When I do the surgeries, I know what things I'm supposed to be taking care of while operating, right from the diaphragm till the perineum, till the episiotomy site. Okay. So once you know that anatomy pit pat, you will be really able to do good things for the patient. So that is the first thing. I think second thing is, especially you and Shilpa madam and Padma Priya madam have seen, and even others, Debashish, all these people, that I'm dead honest to the patient if there is a complication. You know, if I've touched the rectum, I'll be the first one to go out and say that, boss, what? Inadvertently, I touched the rectum. I think we'll have to watch out. Okay. I'll be the first one to go out and tell them that you have a nodule which is larger than what I thought it is. Puckering is more than what I thought it is. I think instead of discoid, it will require segmental bowel resection. Okay. I'll be the first one to go out and tell them that, it's not a unilocular cyst, it's a multilocular cyst. I'll be the first one to tell them that your tubes are unhealthy. So when all these type of things happen frequently, okay, then your non-verbal communication becomes very good to the patient, madam. So the patient ultimately realizes that this guy is really genuine. You know, Usually it was happening in very early days of my career that people would find out or cross-reference, hey, how is this Jay Mehta? Have you heard of him? And usually a colleague would say, I have never heard of him. Who is he? Okay. I think times have changed. Hard work has really put people into their place. And these days, the common perception, even if somebody tells I have not heard of him, then the patient really begins to question that guy. Are you really a gynecologist that you've not heard of him? Because now we are everywhere, right? Right from social platforms till digital media till B2B, B2C, almost everywhere, right? So it's pretty difficult to ignore. And I think that's a very, very important part of a journey, which I think that people must learn to project their good work, and people must learn to teach, because when you teach, you will really learn a lot. You will make mistakes while talking. People will point it out. People will tell you. You will correct, and you will be better in your next session than what you were in the previous session. Is what I think.
Right. Jan, also uh, these patients where we've operated and done these complicated surgeries, I've noticed that you always call back and find out how the patients are, at least for the next 1 week post-op,
Yeah, 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 yeah.
yeah.
Yeah,
So,
I have this habit. It's just a habit. It's not. See, there could be people who are so busy that they don't get the time to do it, right? And but I don't know. It's just ingrained probably as a part of the postgraduate training. So it's become a habit. I will normally ask, how are they doing? I'll normally, in fact, I had operated once with Shilpa madam when it was difficult going for her that time because of we both hardly knew each other and everybody was on her head in Bangalore, and I had operated a bowel resection there, and that patient developed a fistula. Okay, this was small fistula, madam. It was just managed conservatively with Placentrex. But I was in the USA, and I knew that Shilpa madam was handling such type of probable things for the first time independently. So we used to speak twice a day from USA. Okay, and we used to speak to the patient. So sometimes we really go out of the way because it's important, because for that particular patient the result is either 0% or 100%,
Mm.
and one satisfied patient will really bring you a very good goodwill and word of mouth, is what I think it is.
Right. So that was wonderful, Jay. I mean, beautiful take homes about how long you should follow up, how to be honest to the patient. And I myself have seen at our place, when you come, all these complicated surgeries, we talk to the patient together, tell them about what are the possible issues which we may have to deal with. And we never overpromise and underdeliver. I mean, that's another thing that we always should take care of, and document and counsel and be truthful and take extensive consents is another wonderful take home point, Jay. I think we can go ahead and take a few questions. Shilpa, PP, you all have anything to add and ask? And we can, of course, take questions as well.
No, I would like to just ask, because nowadays we are seeing lots and lots of these kind of cases where we begin with conservative surgery and then end up doing hysterectomies. So one thing I would want to ask Dr. J is like, what is it that uh, the pointers during the surgery where he thinks, no, I mean, this is something which definitely needs TLH with BSO, in spite of we just taking a consent even in unmarried. We have done TLH with BSO for an unmarried girl last time when he came. She was just 28 years old, and it was quite a bad disease, of course, but it was not picked up in any of the MRIs or in the scans, though she has had multiples of them. So what is it that, like, tells you that you have to do this kind of radical surgery during on table findings?
See, if the disease, first it has to be a repeat surgery for us to do a TLH-BSO, right? Even in young girls. Second, that repeat surgery should have very bad ovarian endometriosis and deep endometriosis. If you conserve this with adenomyosis, some patient having a focal adenomyoma protruding from that serosa, unhealthy uterus stuck to, we've operated so many uteri stuck to the lateral pelvic wall, right, Shilpa madam? Like nothing is visible between the vessel and the uterus. We have to make a plane between the external iliac vein and the uterus, and then somewhere down the line, patient has been on Dynogest since birth. All these types of cases we've been operating, right? So in these type of situations, you have to have a very broad sort of a horizon, you know, and you need to figure it out that, okay, if I leave this uterus behind, even if I leave this uterus behind, do I give her any shot of becoming pregnant? Okay, if that answer to that question is a no, and if it is her third surgery, second surgery, extensive disease in the pelvis, no harm in telling that patient once that, look, boss, I think it is better you knock it out. I want you to live a happy life, because that ovary is gone. 15 centimeter ovarian endometrioma plastered to the parametrium. Ureter ka koi ठिकाना nahi hai. In all these types of situations is basically when you have seen us taking a call. Otherwise we have done, see, once we had sent you outside, you roaringly went like a lion and you counseled the patient about a total laparoscopic hysterectomy. By the time you came back, we were like, no, no, we will conserve. Again, you ran out like an elephant. You told, what rubbish. We are not going to remove this uterus. We'll conserve it. Right? And we did a bowel resection in that lady because it was a huge, huge, huge nodule. Isn't it? So, uh, sometimes, okay, but that has happened only one case in 102. Okay, so sometimes these type of things will happen, right? Initially, we feel, Arey Bapre, it is very, very bad. Out of excitement, 5 people will run out of the OT. They want to counsel the patient first, like that. Then again, they will come back. Then the mind might change. So such type of things may happen, right? May happen. But obviously, we don't do it routinely.
Right.
Yeah, no, but you are saying that fertility is only the factor which tells you, like, I mean, irrespective of the age, irrespective of she wanting to have her menstruation, because see, menstruation is equivalent, or uterus is equivalent to a womanhood. So the
Not at
perception
the
of
cost of life. It is
no,
equivalent to womanhood, but
no,
it
you
is not at the cost of life, madam. I mean, if the
is
lady is in such severe pain and the pain will come back, then why to give her such a, life, just a 1 year pain-free interval? Why to do that? Somebody may call you harsh. Oh, he is very radical, you just knock out everything. That's why this visit we did not keep a hysterectomy. Correct? Somebody may pass such type of statements. But ultimately, madam, it is for the good of that patient. That patient will also realize that, okay, it was good. What they did kept me pain free. Like, for example, see this visit, that bladder was so badly adherent. Remember, there was that bladder nodule in the one whom we did a hysterectomy. She was having multiple adenomyomas in the uterus. So
cystic
even if
adenoma.
we would have cystic adenomyoma, so even if we would have preserved it, let's assume some new place cystic adenomyoma would have grown, madam. And she would have come back to you with a recurrence.
Yeah.
I actually want to add one point. I'm so sorry, Aarti madam, I forgot to add this. See, sometimes in these young girls who have a retroverted uterus, and after we have finished every clearance, we can't really see anything microscopically. I have this habit, which has no proven track record, to hitch the round ligament on both the sides. Okay, and a lot of people have seen me doing that. And believe me, what that does is it just temporarily keeps that uterus antiverted. It's not a permanent solution. So once the pneumo goes off and the bowel settles down, okay, it is a fresh serosa of the rectum or the sigmoid which settles over the part which you have coagulated on the posterior wall of the uterus. Okay, it is not the dissected part. The dissected part will go very close to the vagina and settle down there. All right. So what it does is it greatly reduces the probability of additions. Okay, it greatly reduces the probability of additions.
Two questions from our colleagues, Jay. One, is there a chance of post-ectopic endometriosis? I think what she meant to say is post-ectopic surgery. Can endometriosis happen?
In ectopic, actually you are knocking out the tube. So going by one theory of endometriosis, there is no retrograde menstruation. So it should be protective for endometriosis actually. But
in ruptured
I mean, today's
ectopic was what she meant. In ruptured ectopic post-surgery, is there an increased chance of endometriosis?
I don't know.
And in unmarried girls, if there is a endometrioma measuring 2 centimeters in size, what should be done specifically and what are the counseling points?
6 monthly follow-up. When the size is more than 5 centimeters, you need surgery. Give continuous OCPs without a break. She should not be menstruating if she is very young. It may probably keep this endometrioma at 2 centimeters. Okay, but it will not arrest the progression of the disease.
Okay. And Jay, you must share also what is weeping peritonitis. I mean, many of our colleagues are not aware of that condition, how it presents.
So it's basically something to do with the CO2. Okay, it is something predominantly related to a CO2 reaction in the peritoneum. Okay, that causes generalized peritonitis, but it is something which is a non-infective peritonitis. So it causes severe loss of third space fluid. I mean, severe loss of fluid in the third space. It can cause a little bit of ascites. It can cause a little bit of weakness in the patient. Albumin can go down. Bowel can become edematous. Can cause paralytic ileus. All these things can happen. But it self-resolves within 8 to 10 days, honestly.
When does it start showing up, Jay?
Usually within 72 hours of the procedure.
Usually, but it can also happen late.
Can happen 7-8 days also sometimes,
And it resolves in a week's time and there's nothing but this conservative management.
Nothing. Expectant management. Tender loving care. Nothing else.
So the recurrence, do you think it is related to the genetics of the woman? Like some women are more prone for recurrence in spite of you being the surgeon doing so many surgeries.
Definitely. Multiloculated endometriosis is the biggest risk factor for recurrence. But if multiloculated endometriosis is also taken out, there can be a recurrence at a fresh site. Appendix, somewhere else.
You tell me, like many people are doing TLH with BSO with like when there is bowel endometriosis or when there is bladder endometriosis or when there is endometriosis of the parametrium and expecting the endometriosis to settle down. Okay, so here their contention is they're taking out the estrogen from the body, and so the endometriosis is supposed to just shrivel out and die out. But it doesn't happen like that. I mean, the patient continues to have pain, the patient continues to be symptomatic, and it keeps I think progressing. So
Yeah,
in such,
definitely.
yeah, how do you explain this, and what would you tell the audience that, I mean, what would be the ideal thing to do in such situations?
See, actually, the principle of surgery in endometriosis is to excise every lesion of endometriosis with wide local margins. Right? So if you have done TLH, PSO and left a bowel nodule behind, it is a R2 resection. You have removed a part of the disease and you have left a part of the disease inside. Then if you think that if removal of ovary is going to cause hypoestrogenism and that hypoestrogenism is going to prevent the nodule from growing, you are wrong. Because the mechanisms in which the nodule grows is not dependent only on estrogen. It is dependent on vascularity also. It is dependent on VEGF also. It is dependent on the amount of peritoneal edema also. How will you control all these things? Right? So, see, by that logic, person should, we should inject GnRH agonist in the bowel nodule. Correct? And what it will do is it will cause such severe hypoestrogenism, especially of the receptors, like a depot in the nodule. Imagine, instead of giving depot in the gluteus muscle, put a CT scan guided depot in the nodule. Correct? What it will do, madam? Nothing it will do. Okay? It will cause whatever little estrogen receptors are there to atrophy. Very good. After that, what will happen? The rest of the receptors will continue to be present. So the disease doesn't settle by removing ovaries.
Yeah, I got it. So you tell me about this peritoneal endometriosis. Like we had a same case, what you did yesterday, where the patient had
Yeah.
unexplained and I had done the IVF, which you were not very happy about, and you expressed it also. And you convinced the patient for a diagnostic histrolab, and we found, and you were sure that it is going to be a peritoneal endometriosis, and it was peritoneal endometriosis. So you did peritonectomy for that patient, and you asked me
Yeah.
to do an IVF in the next cycle. So you tell me, in such cases, okay, if she doesn't get pregnant, all right, even with the IVF cycle, and if she decides to just drop the whole idea of the fertility treatment, so how do you think that we should follow her up as a only isolated peritoneal endometriosis? The ovaries are clear, everything else is perfectly fine, no adenomyosis, nothing at all, but she has only peritoneal deposits that too spread all across the pelvis.
See, in peritoneal endometriosis, one of the first things which goes up is CA125.
Yeah.
Okay. Isolated elevation of CA125 is a marker of peritoneal endometriosis. Second, this peritoneal endometriosis is very close to the ovary, madam. So when the ovary is completely stimulated, we may feel that the ovary is good and it is going to give us great oocytes and all these things. But this peritoneal endometriosis creates a very bad milieu in the pelvis, which shows you good follicles but gives you less oocytes. Your follicle to oocyte ratio is skewed up. Okay. When that happens, suspect peritoneal endometriosis in this patient, which is what we did, right? She came to me with that history. I told her point blank that don't worry, you have peritoneal endometriosis. She was shocked that, how can I have peritoneal endometriosis? I said, 100% you have it, don't worry. She got operated. When we entered inside, the first thing everybody said is, he'll have peritoneal endometriosis. Correct? And I think this is, it's probably not mentioned anywhere, madam. Maybe it is just practical experience of getting hammered so many times. Nothing else.
No, follow up, sir. Follow up. I know. I mean, you did a great job. Follow up.
Once in a year, probably do a CA125 for her, madam.
Yeah. Great.
Probably, yeah. But remember, sometimes you can have a peritoneal endometrioma which is non-secretory also, but very rarely.
Sure. Yeah.
Have you had a patient?
Yeah. I've had in that patient, you should do parametrectomy. I've told this many times that if you have chronic pelvic pain, don't do hysterectomy and come out. Do hysterectomy plus parametrectomy, and it is beautiful. Trust me. Ask Shilpa madam. She will tell you. We have done this for patients. Oh my God. They are so happy because your pain in the pelvis is close to the hypogastric plexus. inferior hypogastric plexus. It's paining due to the edema in the parametrium. Okay, so the minute you knock out the parametrium, lymphatic go, vein go, artery go. Okay, that nodule is like a free bird. Okay, I mean that nerve suddenly becomes happy. Arey, sab log chala gaya types, and the pain goes away. It's very good to do parametrectomy in them.
I agree with this point because two of our patients who had severe pain, who couldn't even walk, I mean, one patient, though, she had seen 20 gynecologists and I was the 21st. So we did hysterectomy with parametrectomy for her. And this was, I think, 3 months back. So she's so grateful that she calls up my associate and she tells that she's completely pain-free. And this is because of the parametrectomy is what I feel. Because her disease was quite severe in the parametrium, though the uterus was kind of looking not so bad. I mean, the proportion of her symptoms to the way that the uterus was looking was not correlating.
We too had two patients, Shilpa, exactly the similar history, and they are very comfortable. It's been 2 months since the surgery was done. So that's a wonderful take home.
Yeah.
Parametrectomy for these patients. Does the parametrium regrow after parametrectomy is what someone is asking.
Parametrium is two things. Vascular parametrium, which you have knocked out. Second is neurogenic parametrium, which you have to preserve. Okay. So the parametrium cannot regrow. It will undergo some fibrosis. But
right. So we thought 20 minutes, Jay, but we are like almost 45 minutes into the session. It was wonderful, so engaging, and so many insights. And I'm sure this is a great foundation for all of our colleagues who want to advance their surgical skills and, do a great job with their patients. Thank you. And Padmapriya, does Padmapriya want to ask anything?
Oh, no, she wants to call him Apple and finish.
Custard apple, yeah.
no, 1 minute she wants to ask.
No, we also had similar cases. I am sure, Jay, the type of endometriosis we've done here,
Yeah.
and I
You are
agree
the
to
best CP.
parametrium.
Yeah.
So I just
We've
like to
done
say,
a lot of parametrectomies in fact, I must tell you, we took one patient for diagnostic laparoscopy in Chennai, where we ended up doing bowel resection. What saved us was our consent. I think Dr. Padmapriya will describe that thing, because that day what saved us was our consent. As a blanket, Dr. Padmapriya had taken a consent that just in case in diagnostic laparoscopy, if he finds there is endometriosis, you will give us the permission to do what is required. Okay. And when we went out and counseled the husband, she came from the US. When we went out and counseled the husband, both of them, okay, the husband and the wife was ready before the surgery. The husband was ready in the intra-op that no problem, sir. We were already told, we've read your consent. And if the bowel has to be removed, remove it. Okay. So I think that shows she's gone back. Yeah. So that shows the importance of a detailed consent is just probably all I want to say.
Right. And there are patients, Jay, who we've also called the husband into the operation theater and shown them the situation where we had to make a sudden decision and then shown them, and then seeing is believing. And they were so happy and comfortable, even though it was a sudden decision to do some sort of a bowel intervention. And the patient is great in just the next post-op day. So that's another thing we should keep in mind, to keep our patients in the loop all the time so that they don't have any surprises. So I think we'll end today's session. Wonderful. And thank you so much, everyone, for joining us. And we'll see each other very soon with masterclasses in the next few days, and the Blast series next Friday. And of course, with the wonderful obstetric masterclasses of PP and Shilpa as well. Thank you, everyone.